So first we'll mention something about the code of ethics. So code of ethics basically is a list of ethical principles that describe the minimal acceptable behavior. This is the definition. No one will ask about the definition. So basically, this is just a list of what we're supposed to watch for. So we're supposed to watch for beneficence, non-maleficence, justice, things like that when we practice. And this is not all inclusive list. So the idea of the code of ethics is to make sure that we have a list that guides what we do. Code of ethics doesn't tell us, it does not tell us what to do. Code of ethics doesn't say you have to do this now. No, code of ethics tells us these are the rules, you follow them the way you like. So we decide how to use the code of ethics. It doesn't tell us which ethical principle takes a priority. So when you are, between two ethical principles, autonomy and beneficence, for example, it is your choice how to decide. However, they say that beneficence in general is a priority, to some extent. In that sense, you can't leave the patient without an option. The patient always needs to get something. And finally, how to solve every situation. It doesn't say that. It doesn't tell you if the patient comes to you and for an early refill of opioid, and you don't know if you're supposed to give the patient the medication or no, and you are thinking about it. Code of ethics doesn't tell you. Code of ethics says you are responsible for beneficence and you are responsible for non-maleficence, and you choose how to use them. So code of ethics is just a list of ethical principles. The list is here. It's in your material. So we have all of them, and we'll go over them in some details. They keep changing they keep moving them around. But this is typically what you will see. Now, few things to just keep in mind. Beneficence is what we know, and I said this is a primary responsibility here. So beneficence is kind of don't leave the patient with nothing. This is a problem. Non-maleficence, don't do harm. We know this, and we'll see this. Respect for others. This is an ethical principle that includes other ethical principles. It includes autonomy, confidentiality, protecting vulnerable, and justice. And we'll talk about confidentiality and protecting vulnerable and autonomy in some detail. Some people always email me and say, is confidentiality or maintaining confidentiality an ethical principle? It is, and also it's a legal aspect. So it is still something you still in the exam can choose confidentiality when you get a question that talks about patient's information and things like that. If you get a question when you think the answer is autonomy, but you can't find autonomy, you can choose respect for others. So respect for others is a big ethical principle that includes other ethical principles. So you get a case and you think, okay, well, the answer should be autonomy in this case, but you can't find autonomy, but you find respect for others. You can choose respect for others. Autonomy would be the first choice, but choose respect for others. Same for confidentiality. If you find a case when you believe that the answer should be confidentiality, you should choose confidentiality. If it's not, you can choose respect for others. Then we have veracity. Veracity is to be truthful, and it causes lots of headache in the discussion. And we have the fidelity, which I expanded a little bit. And we have altruism. Altruism, just to make sure it's clear, altruism is one of the misused ethical principles in questions. Why? Altruism, this is the definition: demonstrate selfless concern for others' well-being. What this means? For altruism, usually it means to go above and beyond. When you as a pharmacist go above and beyond your job, when you do something that you otherwise wouldn't be blamed if you don't do it. So for example, the example I use, you receive a call from an elderly patient who needs you to refill his medication. Great. You refill the medication, and this elderly patient never comes to the pharmacy. We deliver everything. And then this patient, that day, there is a big snowstorm. So the delivery company cancels on you. Your driver calls you and say, I'm not coming. We cannot drive in this weather. Great. But your patient needs the drug. You call the patient, do you have any medication? Because we don't have delivery today. And the patient says, no, we don't. And then you're like, you know what? That's fine. After the shift, after we close the pharmacy, I will deliver this medication myself. This is altruism. Why? You did something that is above and beyond. And no one will say, this is your job. But you decided to demonstrate selfless concern for others. You know what? The patient needs the drug. It's not about me. I will just go and deliver the drug, even though it's bad outside. So that's how we use altruism. Altruism, if you have a patient who's coming to you late at night, so it's like 8:55, you're about to close your pharmacy, and then someone comes to you with a prescription from the hospital. My mother got discharged from the hospital, and the prescription has like 15 medications. It's 8:55, we are closing in 5 minutes. These 15 medications, to fill them, it can take an hour. You know what? I can say, sorry, the pharmacy will close in 5 minutes. No one will blame you for this. Can you come tomorrow? But if you choose to stay and to fill the prescription and call the hospital and fix doses and things like that, then you are demonstrating altruism. If you give up your lunch break, so it's time to go for lunch break, and a patient comes and the patient wants to speak to you, the patient feels comfortable talking to you, and then you know, if I don't take my lunch break now, I will never take it. And then you decide, you know what? That's fine. I will not take my lunch break. Let me talk to you. This would be altruism. So altruism is when you do something that's above and beyond. That's what altruism is. So we will have lots of cases, and we'll apply our knowledge to these cases. We will start first by some discussion about autonomy. Autonomy, as you all know, that's when someone makes his own decision. That's easy. But there are some conditions for autonomy. So not anything that the patient will say in the pharmacy counts as autonomy. So what are these conditions for autonomy? Number one, the patient must be informed. The patient must be informed. I must give the patient enough information about why this decision is good, why this decision is bad, and then let the patient choose. Patient says, I don't want to take this drug. No problem. Let me explain to you. If you take it, what's going to happen? If you don't take it, what's going to happen? And then you can decide. So number one, the patient must be informed. Number two, in the conditions for autonomy is that the patient must be capable. The patient must be capable. Capable means what? Capable of understanding the information. You cannot explain to a child who's 5 years old why the antibiotic is important. If a child is coming to the pharmacy crying with his mother, and he's crying because he doesn't like the antibiotic, you will speak to the child first, right? That's what we typically do. Oh, what's wrong? Why are you crying? Oh, I don't like the antibiotic. I hate the taste of the antibiotic. Then what you're going to do? You'll talk to the child. Oh, you know what? I will give you an antibiotic that has very nice banana flavor. You will love this one. Don't you want to take the antibiotic so you feel better and you go back to school and play with your friends? You know, what are you trying to do? Honestly, you're trying to share information. But if the child persists and the child like, oh no, I don't want to take the antibiotic and keeps crying, will you tell the mother, I'm sorry, I'm not going to fill the antibiotic, it's autonomy? You will not. Why? Because you believe that the child is not capable of understanding the information. So number one, the patient must be informed. Number two, the patient must be capable of understanding the information. This is the kind of things you will use if you get a question and you wonder if this case is autonomy. Number three, the decision must be made voluntarily. There should be no barrier. There should be no barrier for decisions. So these are the three conditions for autonomous decision. Informed, knows what's good and bad about the decision, capable of understanding the information, and the decision is made voluntarily, and there is no barrier. So, for example, you have a patient who comes to you, and the patient says, I'm here to refill my Ramipril. When you refill the Ramipril for the patient, you notice that there is Lipitor on the system that was not filled for 6 months. So you ask the patient, sir, I can see that there is Lipitor on the system also that is not filled for a while. Do you want to take this Lipitor? Do you want me to refill it? And then the patient is like, no, I don't take the Lipitor anymore. Did your doctor tell you to stop the Lipitor? No, I just decided on my own. Can I know why? I took it for like 6 months and I don't really feel like any improvement. I am not like more energetic, nothing like that. So I decided, this Lipitor is not working for me. So apparently this patient is not informed. Why? Lipitor doesn't make you energetic. Lipitor protects your heart. So it is your responsibility. You can't tell the patient, okay, sure, sir, no problem. If you don't feel that Lipitor is working, I will just leave it for now. You can't, because you can't consider this as autonomous decision. The patient doesn't seem to be informed. Then you need to inform the patient. Lipitor does this, Lipitor reduces your cholesterol, Lipitor protects your heart, etc., etc., etc. After you finish, you ask the patient, so do you want me to fill the Lipitor? And the patient is like, you know what? Maybe next time, because I don't have money on me now. So maybe when I have the money next time, it's expensive. When I have the money next time, I will get it. Is this now an autonomous decision? So can I just say, okay, well, sure, next time? No, it's not. It's not yet. Why? There is a barrier. There is a barrier. The patient explained to me that my problem is money. If I have the money, I would buy it. If I don't have, and because I don't have the money, I'm not getting the drug. So the barrier is money. How to handle someone who can't afford his medication is something we will discuss when we start Unit 3 in the first week, when we talk about billing and things like that. So when someone can't afford his medication, what we can do and what we can do to help. So in this case, I can tell the patient, I can offer the patient, you know what? There are other cheaper drugs for Lipitor. I can offer the patient a couple of options. If the patient continues to say no, so I try to overcome the barrier and the patient continues to say no, then that becomes an autonomous decision. Great. Can we judge whether the patient can make a decision or no? I would say be careful with this. Sometimes in a question, they may say, this patient has psychosis, and the patient hears the stuff. Or this patient has dementia. Or this patient has bipolar, or severe depression. What I'm trying to say here is, please don't make a diagnosis in the question. Don't allow a diagnosis in the question to make you decide, okay, you know what? You can't make a decision. I will have to ignore you. So they say, this patient has psychosis and hears things. Like he claims all the time that he can hear voices talking to him. And then it's a scenario, and then they tell you at the end, can you accept this decision? Yes, if the patient can understand my information as I talk to the patient, I can accept the patient's decision. Dementia. Yes, we can accept the decision made by a patient who has dementia. Early in the dementia, the patient is capable of making information and making decisions. It's only late in the dementia when the patient cannot make these decisions anymore. And that's why if you watch the dementia video, what is the first one in the self-care measures? To plan for the future. The patient has to decide who will make decisions on my behalf. See, the patient will decide, even though the patient is diagnosed with dementia, who will make decisions on my behalf when I get to the point when I can't make decisions. So be careful. Don't allow any question to trick you. When they add, this patient has psychosis, this patient, if the question makes it clear in a way or another that this patient is not capable of understanding, or the physician made a decision that this patient is not capable, then fine. Then fine. Otherwise, please don't ignore the patient's autonomy, because the question says, AB is 36 years old with psychosis. And then you say, oh, you said psychosis, no autonomy. No, please don't do this. Oh, dementia, you said dementia, no autonomy. No, please don't do this. And as an example from working in long-term care, in long-term care, we have every year something that's called Care Conference. every resident has a care conference. All healthcare professionals come together and discuss the patient's medical condition and the plan for the next year. The patient can be an 85 years old patient who has advanced dementia. Advanced dementia, doesn't even talk. During the meeting, they bring the patient. The family is sitting there and they bring the patient. Why they bring the patient? Out of respect. Out of respect. The patient doesn't even know who we are, but we bring the patient out of respect. And the patient doesn't make decisions, but we still have the patient sitting with us, listening to us. So please don't exclude the patient from the decision-making process. Don't exclude the patient from the decision-making process just because the question says this patient has dementia. Okay, so that's, can we judge whether a patient can make a decision or no? And then we come to, it's two together. Is there an age for autonomy? Is there an age for autonomy? The answer is no. Some provinces may use the age of 16 because this is the age for sexual encounter, the consent age. Some provinces do this, but generally speaking, the general rule is, at any age, if you believe the three conditions apply, then you should respect autonomy. At any age, if you believe the conditions apply, then you should respect autonomy. A 13-year-old girl comes to the pharmacy asking for Plan B. Can I give Plan B? Well, if you can inform the girl of the good and bad of using Plan B and how Plan B is used and worked and those and things like that, and if you believe that the 13-year-old girl is capable of understanding this information and can make the decision voluntarily, she's not forced to take Plan B, then there is no problem to accept this decision as autonomous decision. So we call these underage who can make the decision, we call them competent minor. So competent minor is underage who's competent, can understand the information and can make a decision. So is there a legal age for consent, for autonomy? No. The legal age in some provinces is 16. However, at any age, if you believe the patient is capable of understanding the information and making voluntary decision, you don't need to worry about it. You can accept it as autonomous decision. Next question. In case of emergency, do we need parents' consent before giving treatment to an underage child? No. No. If a child goes to the hospital with a fractured arm, happened in school due to an injury, the physician in the ER will not wait until they reach the parents. They will fix the arm. So there is no need to wait for this. Same thing for if you have a child in the pharmacy and the child develops an anaphylactic reaction. You will not wait until the parents arrive to ask them, are you okay if we give EpiPen? So same thing. Next question. Is autonomy an endless right, or are there barriers for autonomy? There are barriers for autonomy. So when a patient comes to you in the pharmacy and the patient says, I am here to get my morphine, and you look at the file and you find that the morphine is being filled 5 days early, and you tell the patient, oh, sorry, sir, I can't give you the morphine now, it's 5 days early. And then the patient's like, oh, I thought this is my right to ask for the medication. Well, it's your right to ask for the medication, but there is legal limit to this right. It's early. So autonomy is not an indefinite right that we always have to, like given to. No, autonomy has legal limits. Patient comes to you in the pharmacy and say, I need some Tylenol number 3. Do you have a prescription? No, I don't. Isn't that autonomy? No, it's not autonomy. So autonomy has legal limits. So these are just some thoughts about autonomy. Again, is there an age to accept or refuse treatment? As we said, any age as long as the patient is capable of understanding the information. That's what we call competent minor. Competent minor is someone under typically 16 years of age who's capable of understanding the information. So the 13-year-old girl who comes to the pharmacy saying, I need Plan B, if this girl is capable of understanding the information and making a decision, we call this competent minor. So that's the meaning of this. What about our autonomy? What about our autonomy? Do we have autonomy in the pharmacy? Can we make decisions in the pharmacy? Can we accept and refuse things? Yes. And that's what we call conscientious objection. This is our right as pharmacists to make decisions. But there are some stuff here. So as pharmacists, we can reject service based on our religion, based on our personal, cultural values. That's fine. You receive a prescription for abortion medication. Religiously, you are against abortion. You have the right to refuse dispensing the medication, birth control, whatever it is. So we have the right to refuse, and that's what we call conscientious objection. Conscientious objection, however, has two conditions. So we can't always do it. Sometimes we cannot do it. Condition number 1, we reject the service, not the patient. We reject the service, not the patient. That's condition number 1. So I can say, as a pharmacist, I don't dispense birth control. That's it. Any birth control to any patient. That's fine. You are rejecting the service. But you can say, I don't dispense birth control to teenagers. No, you can't. Because now when you say I can't dispense birth control to teenagers, then your problem is not with the birth control. Your problem is with the teenagers. Then no, you can't. So condition number 1 for conscientious objection is you reject the service, not the patient. You can say, I don't dispense HIV medications. You can say that, but you can say, I cannot serve HIV patients. Yeah, but isn't the same thing? When you say, I don't dispense HIV medications, doesn't that imply you are not serving HIV patients? No, it doesn't. Because if the HIV patient comes to me with a prescription for high blood pressure, I will fill it. Prescription for diabetes, I will fill it. My problem is the HIV medications. So number one condition for conscientious objection is I reject the service, not the patient. Number two condition, you don't impede access to care. Don't impede access to care. Okay, sorry guys, we will just hold for a second. I think someone is coming. Sorry, give me 1 second. I don't want, I will just get the door. Just 1 second. Whom are we missing? Everyone else is online today. Everyone else is online today. So whom are we missing? Sorry guys, 1 second and we will start again. Sorry guys, we needed to get the door for someone. So back to our discussion. So the second condition for conscientious objection is to not impede access to care. What does that mean? If you are the only one who can provide the service, you have to provide it. If you are the only one who can provide the service, you have to provide the service. So I am the only pharmacy in a small little tiny town. There is no other pharmacy nearby. The closest pharmacy is 100 miles away. And the patient comes with a prescription for abortion medication. And for the patient, traveling 100 miles is not an option. So this patient has no choice, but I fill the prescription. In this case, conscientious objection doesn't count. I have to fill the medication. So that's the meaning of don't impede access to care. It doesn't have to be me. If there's another pharmacist in the pharmacy, I can get the other pharmacist to do it. But if it's only me who can do it, I have to do it. If there is no other option, I have to do it. So you can't leave the patient with no choice. You can't leave the patient with no choice. You have to give the patient the option. So these are the two conditions for practicing conscientious objection. Number one, you reject the service, not the patient. Number two, you don't impede access to care in the sense that patient must always have a choice to get the treatment that they are supposed to receive. As usual, we have some questions about this. So when you go for an interview, should you inform the manager who's interviewing you of your conscientious objection? So should you go to the manager and say, oh, by the way, I don't dispense birth control pills. Religiously, I'm against that. So should you mention this to the manager during the interview? So no, you shouldn't. You shouldn't. You shouldn't tell, and the manager shouldn't ask. Because if the manager asks and they don't hire you, you can get them in trouble. If the manager says, are you religiously against dispensing any product? And you say, oh yeah, I'm against dispensing birth control. And then they don't hire you, you will go back and say, oh, they discriminated against me because I disclosed my religious beliefs and they did not choose me based on this. Of course, it may not be the only reason, but you can get them in trouble for asking. It's like when you go for an interview, a lady goes for an interview and they ask the lady, are you pregnant or are you planning to get pregnant too? That's a big no-no in an interview. Because if they say no, the lady can say, oh, because I said I want to start having a family. Then they are discriminating against me based on gender. So no. But when the situation happens, when you are hired and you are in the pharmacy and you get a prescription for birth control, that's when you disclose this and say, sorry, I don't dispense it. And that's why on the previous slide, we said each pharmacy must have a system in place to handle this situation. If we have someone in the pharmacy who has a problem with a specific service, we must have a system in place to handle this. I did work before with a pharmacy technician who refuses not to dispense birth control, who refuses to touch them. Literally, she wouldn't touch them. So when the box comes, that we receive the shipment, she will put all the medications on the shelf and leave the birth control in the box. She doesn't even touch them. So I think I was just working relief, but I think it's fine. Like I totally understood. I put it on the shelf, and if we get a prescription for birth control, I would deal with it myself. So that's fine. That's how simple this this can be. So that's the how to handle this during interviews and things like that. Next question: should the pharmacist tell the patient he's against providing the service? So when this lady comes to the pharmacy and the lady has a prescription for abortion medication, am I supposed to tell the lady, I'm so sorry, I'm not going to be able to fill this prescription because I'm against abortion? No, we will never do this. We will never do this. Why? Because this will make a big scene at the pharmacy counter. Big scene at the pharmacy counter, and you don't need this. So technically, we try to be more, like careful handling this. So we may tell, for example, first assess the situation. First assess the situation. If you get a prescription for a medication that you don't dispense, how to react? First assess the situation. Is there someone else who can dispense it? Yeah, there is another pharmacist who comes today later at 5 p.m. who can give the medication. He has no problem, or she has no problem giving the medication. Sure. Then tell her, you know what? We will have the medication later this afternoon. Would you mind to come at 5 p.m. to pick it up? Fantastic. Then you don't dispense it and you don't lose business as a pharmacy. No problem. And then leave it for the other pharmacist to fill it for you. If you are the only pharmacist and there is no other pharmacist coming later today, then also assess the situation. Can someone else do this? Is there a pharmacy across the street? Is there a pharmacy nearby? Yes. Okay. Then you can say, I'm so sorry. You know what? We don't have the medication. What if the patient tells me, I want you to order it for me? You know what? I'm not sure if our supplier carries this or no. I will need to check, but it can take a few days. You're just trying to be polite about it. But we will not confront the patient because it becomes beliefs against beliefs and it becomes a fight. So we don't want this in the pharmacy. So we'll not tell the patient, I'm against this. Why are you taking birth control? Why do you want abortion? We don't do this. Next question is about referral. Referral. Is it my responsibility? Is it my responsibility to tell the patient where to go? So this patient comes with a prescription for abortion medication. Is it my responsibility to tell the patient, you know what? I don't have the drug, or we don't carry the drug. Would you mind to go to the pharmacy across the street to fill it? Is this my responsibility? No, it is not. I don't have to tell the patient where to go, as long as I know there are other pharmacies and it's something reasonable. Don't tell the patient there is a pharmacy 200 miles away, 2 hours drive, and you'll be there. So it is not my responsibility. It is not expectation that you tell the patient where you can get the service. It is not my expectation to refer the patient to another pharmacy. So that's the referral. If you refuse the service, you don't have to tell the patient where to get it, as long as you know there are options. Fine. But what if the patient asks? What if the patient says, do you know where I can get that? Now, I need to do effective referral. If the patient says, okay, so you don't carry the drug, that's fine, I understand. So do you know where I can go and get this drug? Now, I have to do effective referral. What this effective referral means? It means I have to tell the patient to go to a pharmacy where I believe the service is offered. What does that mean? No tricks. No tricks. So I am against abortion, and the pharmacist and the patient asks me, so where should I go? I'm like, you want me to tell you where to go? You know what? I will send it to my friend Michael, because I know Michael also will say no. Oh no, you can't play with the patient like that. You can't play with the patient like that, because this is not effective referral. But I can say, you know what? Go to the pharmacy for Mariam. I believe Mariam doesn't have a problem dispensing abortion medication. As far as I know, I don't believe Mariam will have a problem. That's effective referral. Effective referral, number one, is not required from you. It is not expectation that if you say, I can't provide the service, to tell the patient where to go. It is not required. But if the patient asks, where should I go? You need to send the patient to a place where the patient will get it. In your best judgment, maybe you will tell the patient, go to Mariam's pharmacy, and Mariam also is against abortion. You don't know that. That's fine. But to a pharmacy where the patient will receive the service. So that's what we call effective referral. What if the patient tells you, oh, you know what? I don't want to just go around from one pharmacy to the other, because this is wasting my time. Can you please call around and see which pharmacy carries the drug? Then you have to. You have to. You can say, you know what? I am busy. This can take some time. I'm like, oh yeah, no problem. I can wait. Yeah, you have to. You can't just say no. You can, if you don't like it, you can say, oh, you know what? This will take some time, and we're very busy. So to get time to call around, this will be a problem. Remember, it's not expected that you will be the one who will call. It's probably one of your pharmacy assistants will call. But yes, you should try to help the patient find the source, because remember, if there's no one else can do it but you, then you have to do it. So there's no problem with that. If the patient says, can you please call around and find which pharmacy carries the drug? You should, you have to do this. Next question. Can the pharmacy terminate a relation with a patient? Do we have the right to terminate the relation with a patient? Yes, we do. Yes, we can. Sorry, guys, there is a noise online. Can the pharmacist terminate the relation with a patient? Yes, we can. Yes. If the relation becomes toxic, then there is no problem to terminate the relation. We usually do it very politely. I did this once with a patient. Once. You know, Sometimes when you work in a pharmacy and certain patients, when they walk into the pharmacy, you feel that they absorb all the oxygen and everyone is like, can't breathe. It happens. Some patients, when you see them coming from the door, like, oh my God, all the staff will be like going to the bathroom and having lunch break. Like everyone will try to hide. It happens. It happens. So in a situation like that, when you feel that the relation between the pharmacist and the pharmacy and the patient is not working, you have the right to terminate the relation. I did this before. We sent the patient a letter on the address, on his address. And the letter was actually very nice and doing nothing except blaming us, even though we are the victims in the relation. But it was like, we noticed that lately we are not able to meet your expectations. See, we are the bad guys. And that's why we believe that it's better for your care to find another pharmacy that can serve you better, etc. So we were polite. We can't just send a letter to the patient saying, because you have been very rude, we decided that we don't want to see your face in the pharmacy anymore. We can't say something like that. We have to be very, very polite and very respectful and describe this. So that's what we did. Like lately, we were not able to meet your expectations. You want your prescriptions to be filled fast. We cannot do this every time. Things like that. So you know what? You probably should find another pharmacy. And then we give them a time. So we expect that as of April 1st, like 2 months from now, as of April 1st, you transfer your prescriptions to another pharmacy, something like that. So yes, we can terminate the relation with a patient. Offer referral when requested. That's the effective referral. I have here another question. So a pregnant lady comes to the pharmacy. You may not have this. It's just a scenario, a story. A pregnant lady comes to the pharmacy and says, you know what? I'm pregnant. And I want to have abortion. You are against abortion. And the lady said, can you please just tell me what are the options available for abortion in the pharmacy? What medications are approved for abortion? And then you go, well, what can I do now? She doesn't want you to give the drug. She just wants you to write down the names of the drugs approved for abortion in the pharmacy. So, and when you tell the lady, you should speak to your doctor about this. And she's like, yeah, I will, but I want to know what's available. I want to do some research first. Then when I go to my doctor, I'm informed and I know exactly which one I want. In this case, this is something to please keep in mind. Conscientious objection doesn't apply to knowledge sharing. Conscientious objection doesn't apply to information. When you are against dispensing birth control, you are against dispensing birth control for religious reasons. And this lady comes to you and say, I take Alice and I forgot to take my tablet yesterday. What should I do today? You as a pharmacist can say, oh, I don't know. It's unacceptable answer. It's unacceptable answer to say. You can't tell the patient, oh, I don't know. The expectation will be go and check your reference and tell me. So conscientious objection doesn't apply to knowledge. Patient comes and say, my doctor prescribed for me this abortion medication that I got from another pharmacy. Sure. I know you guys have something that you can print on your system that has some information about the drug. Can you print this for me? You can say, oh no, we don't have this. I can't print it. Conscientious objection doesn't apply to knowledge. You cannot refuse sharing knowledge. If a lady comes to you with 2 packages of birth control and the lady asks, so what is the difference between the mini pills and the Alice? You can say, I don't know. Oh, mini pills is one hormone, Alice is combination, etc. So conscientious objection doesn't apply to knowledge. The next piece we will discuss here, and we have smaller pieces at a time, is confidentiality. And again, as I said before, some people will say, is confidentiality an ethical principle? If you have a case in the exam, the answer is confidentiality. Choose confidentiality 100%. There's no problem with that. So confidentiality is a legal issue. It's an ethical issue. It's a big thing in ethics. And it's a standard of practice as well. So confidentiality is a standard of practice. Maintaining confidentiality is a standard of practice, is ethics, and is laws. So it's important. Each province has a piece of legislation that talks about confidentiality, and usually the provincial laws are more strict, so we follow them. Someone asked before and said, can you just give us an overview of the PIPEDA? PIPEDA is the federal piece of legislation that talks about confidentiality. So you have this in the book. What I did here is I just highlighted the key messages. You don't need to read this, like you don't need to worry too much about it. So according to PIPEDA, each pharmacy must have a privacy officer. Each pharmacy must have a privacy officer. That's according to PIPEDA. Your provincial laws may have different requirements, and that's typically what we follow. So each pharmacy must have a privacy officer who can handle any complaints about confidentiality and things like that. If you work in a pharmacy, your pharmacy manager is the privacy officer. And then it says here, before gathering information, we need to identify the purpose. We should inform the patient why we need the information. This is what we do in the OSCE. In the OSCE, when you want to ask the patient about his medical conditions and allergy, what do we say? What do we say? We say something like, in order to assist you, would you mind if I ask you a few questions? It is this line, in order to assist you, this is the purpose. I need to ask you questions to assist you. If the patient is coming for non-prescription drug recommendation, you say what? You say, to recommend the best drug for you, I need to ask you a few questions. Yes, I need, in order to recommend the best drug for you, that is the purpose statement. So before we ask the patient any questions, we should always explain the purpose, why we need to get your information. Imagine you walk in the mall and someone stops you and say, are you diabetic? Who are you? But if this person says, I am a nurse and we have a research, we are conducting a research and we need to gather some information, now they explain the purpose, you may choose to answer the questions. So we need a purpose. The pharmacy staff must obtain the patient's consent for the collection, usage, and disclosure of the information. And that's why for the OSCE, this slide is good, like applies more to the OSCE. For the OSCE, when we decide to call the physician, because the dose is high or the dose is low or there's a drug-drug interaction, what do we say? With your permission, I would like to call the physician. See, with your permission, what I'm doing, I'm obtaining a consent. So we need to obtain a consent together. When you tell the patient, in order to assist you, I need to ask you a few questions. Are you okay with that? What is this consent? So we need a consent for the information. And then it says here, the information collected should be limited and relevant to the purpose for which it's collected. What this means, only ask questions relevant to what you need. Only ask questions relevant to what you need. If you have a patient who comes to the pharmacy saying, I need something for athlete's foot, and then you ask the patient about allergy and everything, you ask it everything. And then you ask the patient, so are you sexually active? What does sexually active has to do with athlete's foot? That's inappropriate. So when you ask questions, you should limit your questions to what's relevant about the patient's condition. So sexually active can be a question for vaginal candidiasis, but it's not a question for athlete's foot. So always ask relevant questions to the patient. It is the pharmacist's responsibility to ensure that information is protected against disclosure. This is our job. Each pharmacy must have a privacy policy. If you work in an independent pharmacy, they may not have this. But if you work in a big company, Walmart, Shoppers, they have privacy policy. The patient has the right to access his or her information. Please, this is important. Why? Patient can come and say, can I see what's on my file? Why this is important? Because when you document something on the patient's file, you have to be mindful of this. And we'll discuss that later. You cannot document something on the patient's file says, this patient is very rude. You can't say that. The patient has the right to come and say, can I see what's on my file? And the patient will not be very happy to say that, to see that on the file. So keep in mind, patients have the right to see what they have on their file. Number 10, the pharmacy must have a mechanism to receive, investigate, and resolve the complaints regarding privacy. These are key points from PIPEDA that are related to the pharmacy. We must have a privacy officer. We must tell the patient why we need the information. We must obtain a consent when we gather the information. We should only obtain information relevant to the condition that we have. We must have a privacy policy. Like these are just some key points from PIPEDA. The consent. But before we talk about the consent, let's talk about this. Let's talk about what is considered patient's health information and what is considered health information custodian. So before we decide what is consent and what consent we need to know which information we are supposed to keep confidential and which people we can share the information with them. When we say which information we should keep confidential, people will say, oh, I cannot tell what the patient takes, like medications or what medical conditions the patient has. That's right, but this is only one piece. There are lots of information that we are supposed to maintain as confidential information. So what is this? Patient's physical or mental health, including the drugs used to treat these conditions. Yes, we all know this. I cannot tell someone that your neighbor has psychosis. I can't. And I cannot tell someone that your neighbor takes quetiapine. I can't. We all know this one. But there are others. We cannot tell other people about health providers. For example, someone comes to you in the pharmacy and tells you, listen, I know you guys have your confidentiality laws and you cannot share any information with me. Fine. But I was talking to my neighbor one time and my neighbor told me that he goes to a great dentist, but I didn't get the name, or he gave me the name and I forgot. I don't need you to tell me, I don't want you to tell me what my neighbor has as medical conditions or what medications he takes, nothing like this. I only need the name of the dentist that my neighbor goes to because I broke my tooth and I'm in so much pain. You can't. You can't provide the name of the dentist. We can't share information about providers. What you can do then, the guy's in pain, you can recommend some names. You can tell the patient, you know what? I can give you some names for good dentists in the area here. And you know what? You can include the name of the dentist for the neighbor. So I can give you 3 names for good dentists. And even if you include the name of the dentist that the neighbor goes to, that's fine. But you did not say your neighbor goes to this dentist. So we can't share information about health providers. That's confidential information. Great. We can't share information about donation of body parts or body fluids. A patient comes to you in the pharmacy and you ask the patient, how are you doing? And the patient says, oh, you don't know what happened to my wife. My wife got an injury and she's in the hospital and we have a problem finding blood for her because her blood is O negative and we can't find blood. She needs blood urgently. You know that you have one patient, one of your patients, who's O negative and who regularly donates blood. I cannot tell this husband, oh, you know what? I have someone who does that. No, this is confidential information. I cannot tell the husband, I have a patient who donates O negative. I can say that, but I don't give name, I don't give contact. So will we leave the lady suffering? No, I can call my patient. I can call the patient who donates blood and say, just to let you know, I have another patient in the pharmacy. His wife is in the hospital and she needs O negative blood. Can you help? The patient may say, oh no, you know what? I just donated blood yesterday. I cannot donate other blood today. Okay, then we can't. That's it. But who knows? Maybe the patient who donates blood will say, oh yeah, share the information share my contact information, and I will call them and claim for this. No problem. So we cannot share information about donation of body parts or body fluids. We can share information about payments or eligibility for services. That's the important one, and the tricky one. So a wife goes to the pharmacy, and the wife says, I need to know, or I need to have a list of the medications that my family members take. The answer is obvious. How old are they? They are all adults. The answer is obvious. We can't. Nice, done. Then the lady, the mother, the wife tells you, you know what? I appreciate that you cannot share with me a breakdown of what they take, but can you give me the total amount that each one of them paid last year? I don't need drug names. Just give me a total amount. Your husband spent $300. Your daughter spent $200. Your son spent $150. That's it. I don't know. I don't need to know what they take. How do you feel about that? So no drug names, just lump sum of money that everyone spent in the hospital, in the pharmacy last year. How do you feel about that? That's a no-no. That's a no-no. Some people will say, yeah, but it has no drug names. Payments information is confidential. So please remember this one. We can't give just a lump sum of money. We can't. And if you think about it, it can cause troubles. At the family level, this can cause problems. When this mother comes to the pharmacy and asks for this request, and you give her the total amounts of money, the mother has idea of what the family members received as medication. So the mother can say, oh yeah, my husband, I know he takes blood pressure medication. So how much will this be? $100? Then I come and say, oh, your husband last year in the pharmacy spent $700. What? 700? Why? What does he take? See, you created the problem just by releasing the number. So information about payments is confidential. What about eligibility for tax purpose, for insurance purpose, for anything? Information is information. Information is information. Yeah, so the tax purpose doesn't make it okay to give the information. What about eligibility for service? So someone comes to you in the pharmacy, and this person tells you, you guys are not good as a pharmacy. Why? What did we do? I was talking today to my friend, and my friend told me, we work in the same company, we have the same insurance, and we come to you, same pharmacy, and we take the same medication for blood pressure. But my friend told me when he comes to you, he pays nothing, but you charge me for every time I come to you $5. So why are you doing this? I need to get the same deal like my friend. When you check the friend's file, you find that the friend has secondary insurance by his wife that pays the $5. I can't say that. I cannot go and say, oh yeah, because your friend's wife has a job, your wife doesn't have one or doesn't have insurance, so that's the reason. I can't say that. I can't say about eligibility for, like, I can't talk about coverage. What I can say, I checked your file and your friend's file, and I can tell you, we are not causing any discrimination. Your friend is supposed to pay $5, but this $5 is handled by something else. Like, you know, like you can't say your wife has his wife has insurance. You need to speak to your friend to see if your friend has another coverage or anything like that. But at our level, we treat you the same way. Or if you find the friend has provincial coverage, like Trillium program, if you are in Ontario, you can't also share this information. So as you can see, when we talk about confidential information, it is not only drugs and diseases. It is much broader than this. We will talk about the ages. Information about substitute decision maker also is confidential. So someone comes to you and say, actually, we had this in practice. So a pharmaceutical company came to us and they asked us to release, because we serve nursing homes. They have an expensive drug, and they asked us to release the names of the substitute decision makers for residents in a nursing home, so that they can contact them and see if they're okay to get the physician to prescribe this drug for them. So they don't want anything. They just want who makes the decision on behalf of these patients. Of course, we can't share this information. We can't share this information. Someone comes to you in the pharmacy and say, I like the house across the street. I want to buy the house across the street. When I went there, I knew that the house is vacant. There's no one there. And the owner lives in a nursing home. And it's the son makes decisions on behalf. I need to get the information for the son. I want to call the son and say, can you sell me the house? We can't share the information. So as you can see, confidentiality goes beyond drug names and diseases. It's broader than that. Perfect. What are the health information custodians? Health information custodians are those who are legally authorized to gather patients' information, and they have the responsibility to protect this information. We call them health information custodians. So health information custodians, we have a list here. Healthcare professionals, including drug list practitioners like physiotherapists, healthcare professionals who are providing care to the patient. So pharmacist is a healthcare professional, family physician, cardiologist that the patient goes to. These are all healthcare professionals. That's sometimes what we call circle of care. The healthcare professionals who provide care to the patient. This includes those who don't prescribe medications. That's what we mean by drug list practitioners. Those who don't prescribe medications, like physiotherapists. So if the physiotherapist calls you and say, I have a patient who comes for physio. I want to make sure that the patient doesn't take blood thinner because I'm afraid some of the movements can trigger or burst some blood vessels. So I want to make sure that the patient doesn't take blood thinner. The physiotherapist doesn't prescribe blood thinners and doesn't prescribe any medication. Can we give the information? Yes, we can. So these are the health information custodians. Also, social workers are considered health information custodians as long as they are providing care to the patient. Hospital operators, hospital clerks, like hospital clerks, operators of independent health facility, like the receptionist, administrator of nursing home, pharmacy operator, like the assistant, lab personnel, ambulance service, and staff. So what is this? In many situations, when you call the doctor's office to refill a prescription, you don't speak to the physician. I can't recall even talking to a physician ever on the phone. We speak to the receptionist. So when we speak to the receptionist, we give the patient's name and we give the drug name, even though the receptionist is not a physician and not a nurse. That's fine, because the receptionist in the doctor's office is considered a health information custodian. When a patient comes to the pharmacy, the patient gives the prescription to the pharmacy assistant. No one questions that. Why? Because the pharmacy assistant is a health information custodian, and so on. So these operators are considered health information custodians. Also, the Ministry of Health in every province is considered health information custodian, and that's true. They get all the information anyway. Medical officers of health and Community Care Access Center. Community Care Access Center is this organization that we did talk about in class number 1. This is the organization that gives the patients access to care. So these are the health information custodian. So now we identified two things. We identified what is considered patient's health information that we're supposed to protect, and we identified those who are legally authorized to have access to patient's health information. Now we will go back to the consent, because now the consent will make sense. Consent, when we get a permission from the patient to share information, the consent has two ways. We have the implied consent and we have the express consent. What is implied consent? Implied consent, when I believe if the patient was here, the patient would say, share the information. That's the implied consent. Implied consent is when I assume that I have the consent. That's the implied consent. I say to myself, I believe if the patient was here, the patient would say, give the information. When can I use this assumption? If a wife comes to me and the wife says, I need to know what my husband takes, can I assume that if the husband is here, he would say yes? No, I can't. So this assumption that the patient would say yes, give the information, can only be used when you have two conditions. Number one, you are giving the information to a health information custodian, and we define them. Number two, the health information custodian needs this information to provide care. Yes. So you receive a call from a family physician saying, I want to prescribe a drug for Mr. X, but before I prescribe the drug, I just want to know if Mr. X takes any blood thinners. Mr. X is not here, is not in the pharmacy. Then let's assess the situation. Who's calling, asking for the information? A family physician. Family physician is a health information custodian. Yes. And why does the family physician need this information? To provide care. So here I can use the implied consent and say, I believe if Mr. X was in the pharmacy and I ask him, are you okay to share this information? I believe he would say yes. So here I will use the implied consent. Implied consent is when you assume that if the patient was here, the patient would give me the okay to share the information. When can I use this assumption? If I'm sharing the information with a health information custodian for the purpose of providing care. By the way, the patient has the right to hold or withhold the implied consent. But we'll discuss this in the cases where the patient says, don't share any information with my cardiologist. Okay, then that's fine. We can't. We will discuss this later in our cases. The other way of getting the consent is explicit or express consent. When the patient tells you, yes, you have my consent. That's the patient telling me this clearly. Yes, you have my consent. When do I need the explicit consent? When the two conditions don't apply. Wife comes and say, I need to know what medications my husband takes. Is the wife health information custodian? No, the wife is not health information custodian. It's custodian. She's custodian of everything else, but not health information custodian. So the wife is not a health information custodian. Yes, I need express consent. I need to speak to the patient and I want the patient to tell me, yes, you have my consent. Fantastic. So these are the two different types of consents, implied and explicit. And as we said, consents can be withdrawn. I can tell you, share the information with my wife now, and I can come after 2 years and say, please don't share the information with my wife anymore. Consents always can be withdrawn. How can we protect confidentiality in the pharmacy? So many things. So many things. For example, we use shredder. We use a shredder to make sure that if there's anything that has sensitive patient's information, we can shred that. When we speak about patients in the pharmacy, we should make sure that our voice is not loud. So when you discuss patients' medications with another pharmacy staff, make sure you're not speaking loudly. Use what we call privacy screens for your computers. Privacy screen is something you put on the computer monitor to make sure that people don't see what's on the computer monitor. That's something also you can use. Garbage bags. Garbage bags. When you use garbage bags in the pharmacy, use non-see-through garbage bags. So if something, piece of paper goes in the garbage that has patient's information, no one can see it. By mistake, we put the patient's profile in the garbage, no one can see that. So that's another thing. Protect your computers with password. Yeah, this, like, it's not necessarily an inclusive list of what we can use, but these are just some ideas. Like shredder, when you speak about patients' information, make sure that your voice is not loud. Have a private counseling area. Have a private counseling area. So when a patient comes and you discuss medications, invite the patient to the counseling area. Using privacy screens or private screens for the monitors. Using non-see-through garbage bags. Another thing you can do for confidentiality, when the patient gives you any packages, so sometimes people come with a vial and they say, can you refill this? If you take the vial from them, make sure you remove all the patient's identifiers or use a marker to hide the patient's name and things like that before you put the vial in the garbage. Lots of things we can do in the pharmacy to protect confidentiality. If you have a fax machine, you receive your prescriptions on a fax, make sure your fax is not accessible. So people don't come to the pharmacy counter and they find the fax there and they can see the fax is coming with patient's information on it. So lots of things. What is the minimum age that mandates protecting patient's information? And what is mature minor? Same what we said with autonomy. Remember what we said with autonomy? With autonomy, we said at any age, and then we put the conditions for autonomy. Same thing for confidentiality, at any age, but the condition here is different. At any age, if you feel that sharing information can be a problem for the patient, don't. A mother comes to you, and the mother says, I want to know what my daughter takes. You look at the daughter's profile, and you find that the daughter is 14 years of age, taking birth control. In your judgment, if the mother doesn't know that the daughter takes birth control, this can be a problem for the daughter. In your judgment, you may see other signs. You may see that the daughter gets the birth control from walk-in clinics, not from the family. Like you see signs that tells you this girl doesn't want the family to know about this. Then you don't share the information. So at any age, whenever you have a concern that sharing the information can be a problem, you don't share the information. You don't share the information. But please be reasonable. Be reasonable. In what sense? When a mother comes to me and say, what medications my daughter take? And I look at the file and find naproxen, and it says take 1 tablet as needed. What is my concern about naproxen? Like, why naproxen is a problem? Why would telling the mother that your daughter takes naproxen will put that girl at risk? Then you can share the information. But the age is 16. 16 years of age, you can share information. Risk, no risk. Thank you so much. I can't share anything. So that's the age. The minimum age is 16. But at any age under 16, if you have a concern that sharing the information with caregiver can put the patient at risk, don't share the information. And this brings us to something called mature minor. Mature minor is someone under 16. We said something similar in autonomy, but we called it competent minor. Here we call them mature minor. No difference. Same thing, different laws, use different languages. Mature minor is anyone under 16 who asks for privacy. A girl comes to you, 14 years old, gives you a prescription for birth control, and the girl says, I please want to make sure that my parents don't know I take this medication. You have to protect the information then. So mature minor is someone under 16 who asks you to protect the information. Then we have to protect the information. But someone may say, what if there is a risk to the girl? Like, this girl is 14, yes, but how do I know that, for example, the girl who's 14 told me that she's in sexual relation with an adult? So this can be child abuse, like she's sexually harassed or something like that. Am I supposed? Your job is to educate and monitor. So you need to tell the girl, you know what? It's a good thing to inform your parents about taking the birth control, or about this relation that you're in. This is your job, to educate. Unless, as we'll discuss, you feel there's an imminent risk, but that's a different story. Question: how should accidental disclosure be handled? So if someone gets to know information about a patient by accident, how can we handle that? Someone comes to the pharmacy to pick up his medication. So the staff got the medication from the drawer, and it's in a plastic bag because it needs counseling. The patient needs counseling. So they put it in a plastic bag. Then the patient tells you, oh my God, I'm sorry, I forgot my wallet in the car. I will just go and grab my wallet. No problem. Patient goes to grab the wallet, medication is on the counter, and then someone comes to pick up his medication, another patient, and then the patient looks at the bag that's on the counter like, oh, this medication is for my neighbor. I know this guy, he's my neighbor. Oh, he takes quetiapine, that's an antipsychotic. Oh, this explains lots of his behavior. Accidental disclosure. Correct? Yeah. So how we handle this? We handle accidental disclosure pretty much like a dispensing error. What do we do in the dispensing error? We'll discuss this in Unit 3. We have to inform the patient. When the patient comes, we have to say, I'm so sorry, your neighbor was here, and your neighbor got to know that that's what you take. And then see if there's anything you can do. Is there anything I can do to help with this situation? Okay. And then investigate. Investigate. We will investigate why this happened, and we will take actions to make sure it doesn't happen again in the future. And I will let you know what we'll do. Same like dispensing error. So inform the patient. I'm so sorry to let you know there was a disclosure of your information. Sometimes you will even hear this on the news when there's like a leakage of information from like a big company. Someone got access to the information. They call clients and say, we are sorry, your information was breached. So inform the patient there was a disclosure. See if you can help. Maybe the patient will tell you, oh, don't worry about my friend. My neighbor is my friend. He was just making a joke. Don't worry about it. Yeah, he knows what I'm taking. Okay, well, that's different, right? So that's good. You still need to investigate, but at least you know that there is no harm. Then investigate. Take actions to make sure it doesn't happen again. And finally, tell the patient. And we'll discuss this again in details in how to handle dispensing errors. Next piece we have is protecting vulnerable. Vulnerable are people who can't help themselves. People who can't help themselves. They are either because they are too weak to help themselves, or they don't know they are at risk. They don't know they are at risk. We have the responsibility of protecting them. So how can we do this, or which people are at risk? Number one, these are situations, or something to keep in mind, these are situations when we may break confidentiality. We may break confidentiality when someone is at risk and we are trying to protect this person. We will take some, not examples, but when we can break confidentiality to protect someone. Number one, when there is a reasonable ground to believe that the patient or the public is at imminent risk. So one of your patients comes to you today and the patient tells you, you know the patient for a long time and the patient has severe depression. And you know the patient is suffering for a long time for suicidal ideation. And this patient comes to you one day and say, you know what, I think that's enough. I am just going now to commit suicide. I will go and jump off a bridge. You know that this patient has suicidal ideation, and you believe this patient is at imminent risk. In a situation like that, you can break the confidentiality to protect the patient. Yeah, but isn't that autonomy? Well, it's autonomy if the patient is making the decision voluntarily. But your concern is that the patient is under the influence of a mental condition. The patient has no control over these thoughts. So that's why I will try to protect this patient. I can call the family. I can call the physician. I may even call the police. I can try to give the patient, calm the patient down, have the patient to stay in the pharmacy, give the patient the crisis helpline for patients who want to commit suicide. You can do this, but the patient refuses. You can call the police and say, well, this guy is going to commit suicide. Don't forget, this patient who's going to commit suicide will jump off a bridge. This actually can harm others too. If it's a highway or something like that, well, other cars may start, hitting each other because they are trying to avoid him. So that's why we may take the action to break the confidentiality in a case like that. It is not our first choice to break the confidentiality, but if this is what comes to, it comes to that. And we had a case in narcotics, remember? When we gave the wrong strength of morphine to someone who traveled, we said that we will need to talk to this person. And we'll call the son. And even if the son says, I need to know what my father takes, we will say, your father takes morphine. We will break the confidentiality to protect someone who doesn't know he's taking the wrong strength. So that's one situation when we protect vulnerable. So here, the patient can't help himself. He can't control these thoughts to commit suicide. Another situation when we can protect vulnerable is when we become aware of sexual abuse by healthcare professionals. We'll take this slide and then we will take a break. When we try to protect victims of sexual abuse by healthcare professionals. So what is sexual abuse? First, sexual abuse is anything of sexual nature. This can be not only intercourse, that's what people will think about. It can be comments, jokes, touches, text messages of sexual nature. These are all considered sexual abuse. So that's the definition. Sexual abuse is not only about intercourse. So if you become aware that one of the pharmacy staff, like regulated pharmacy staff, technicians or pharmacists, is sending inappropriate messages to one of your patients, this is considered sexual abuse. So this is number one. Number two, it applies to workplace as well. What does that mean? Pharmacists cannot sexually abuse one of the staff. And this happens sometimes. There was a case like this in the OCP Pharmacy Connection magazine about a relief pharmacist who went to a pharmacy one day working with a young female technician. And apparently the pharmacist made some comments. And this young technician next day told a more senior technician about the pharmacist and what the pharmacist said. And the senior technician is the one who complained to the college. And it was found to be sexual abuse. So it can apply also, it also applies to workplace. What if the patient is not worried about it? So you have A patient comes to you in the pharmacy. This patient is someone you know. Always the patient talks to you, and then the patient tells you, guess what? Yesterday, I went to my doctor's office, and my doctors and me always talk to each other and things like that. And then for the first time, my doctor told me, why don't we go out for dinner? So went out for dinner, and after dinner, my doctor invited me to go to the home, and we had a sexual relation. Your patient doesn't seem to be very worried about it, like telling you the story normally, no problem, no stress, no tears, nothing, just telling you the story like as if we had fun. Is this now your concern if the patient is not worried? If this patient seems to be okay with it, is this something you need to worry about? If the patient is okay, or if the patient is okay, I'm good. You have to be worried about this. It doesn't matter if the patient is worried or not worried. This is considered sexual abuse unless the conditions are met, as we'll discuss. But even if the patient is not worried, the patient may not know this is wrong, or the patient may be too scared to express his or her concern. Maybe the patient in mind say, if I say no, if I said no yesterday to my doctor, I'm afraid that my doctor would inform my employer that I'm taking an antipsychotic and they would not give me the promotion I'm waiting for. So even if the patient seems to be not worried about it, this doesn't necessarily mean that the patient is accepting it. So we have to still intervene even if the patient seems to be okay. So that is something to keep in mind. Now, what is the problem with the sexual abuse? Like, why is this an issue? Why, if the patient is not worried about it, why do we worry? The problem with the sexual abuse by healthcare professionals is power difference. Power difference. What is power difference? In any relation, the two partners must be equal, have the same power. Any one of them at any point can say, you know what, this relation is not working, I'm leaving. Sure. But when the relation is between a patient and a healthcare giver, a healthcare professional, there is a difference in power. The healthcare professional in this relation has more power. What power? Access to medical information. This access to medical information may scare the patient to leave the relation. So the patient is always afraid. If I say I don't want, this healthcare professional can use my information against me. That's why we have to be concerned about sexual abuse. Is there any way? So we will come to this in a minute. So what if the patient and the healthcare providers agree to the relation? So we got the idea. There's a difference in power. But what if they agree to the relation? They want to have the relation. Can a patient have a relation with a health professional? There are two conditions. So the relation can happen, but there are two conditions. Number one, change the healthcare professional. Terminate the relation. Terminate the relation. Yeah, you want to have a relation with the physician or with the pharmacist? No problem. But terminate the relation before you start the intimate one. Then it's okay. Then you are not his patient or her patient anymore. Then that's fine. In Ontario, they made it even harder. And they said there must be 1 year between terminating the relation and starting the intimate one. Don't terminate the relation in the morning and start your intimate relation in the evening. No, still there is some power difference there. So what if the patient and the healthcare provider, they want the relation? Number one, terminate the professional relation before starting the intimate relation. What if this is not an option? I am the only pharmacist in town. Am I supposed to live single for the rest of my life because I'm the only pharmacist in town? No. If you are the only one who can provide the relation, the service, then the patient must accept the power difference. I'm the only pharmacist in town, no other pharmacy. No other pharmacy in town. And this patient comes to me and we are attracted to each other. But there's no other pharmacy in town and the closest pharmacy is like 100 miles away. What should we do? In this case, the patient must accept the power difference. I have to explain to the patient, by the way, if we start this relation, I will have more power than you because I know what medications you take and what health conditions you have. Are you okay with this difference? It's not necessarily mean that I will use it, but are you okay to have that I have this more power than you in the relation? And it is recommended to have this in writing. It is recommended to have this in writing. If the patient accepts this power difference in writing, because there is no healthcare professional who can provide the same service, then that's fine. So these are the two conditions. What if the patient and the healthcare provider agrees to the relation? One of two things must be met. Number one, the professional relation must be terminated before the intimate relation starts. That's number one. Or if terminating the professional relation is not an option because this is the only healthcare professional who can provide the service, then in this case, the patient has to accept the power difference, preferably in writing. Great. What if the patient says, don't report? So when I ask the patient who came to me telling me about the physician story, I need to understand. So I ask the patient, so did your doctor tell you to go to another physician? Like, did you guys terminate this professional relation first? No, my doctor is a good doctor. Why should I go somewhere else? Okay. Did your doctor explain to you that there's a power difference between you and the doctor in this relation? What power difference? Okay, so apparently I have to be concerned here about sexual abuse. I have to be, so I can share, you know what, this is inappropriate. And then the patient tells you, oh, don't take any action, don't report. Okay, I don't want you to report. Then what? Then what? Should you report? Or the patient told me don't, and that's it. You have to report. You have to report for reasons. Reason number one, the patient may be scared that something's going to happen if you report. That's number one. Number two, what about other patients who may have been sexually abused and they never speak? So we need to report, even if the patient says don't report. And remember, when you report, you don't say this physician X had a relation with patient Y. You don't disclose names. You just say that physician X, I became aware that's what's going to happen. That's what's happening. So you're not sharing that name of the patient. So even if the patient says don't report, if the patient says don't report, then ask the patient, you know what, then if that's something ongoing, you should terminate the relation. Oh, I'm not going to terminate the relation. You know what, let's report them. If I decide to report, where do we report? We report to the college of the other healthcare professional. So if the other healthcare professional is a physician, we report to the College of Physicians in the province. Dentist, College of Dentists in the province. Pharmacist, College of Pharmacists in the province. That's where to report sexual abuse. You don't have to tell the patient you are reporting. Again, patients can get too scared. Patient can get too scared. So let's take our first break for today. Okay, not to the police. No, not to the police. You report to the Office of Controlled Substance. Controlled Substance. You report to the College. Police and Office of Controlled Substance, in my mind, are interconnected. No, you report to the College of the other healthcare professional. And if they find the physician or the healthcare professional to be guilty, then it will go to it will be escalated from there. Okay, so let's go and take our first break. Let's be back at noon, and we will continue this discussion about ethics. Okay, enjoy your break, my friends.